نرجع لأرض الواقع من this fantastic session of TAVI, which is actually becoming an everyday practice abroad. لكن هنرجع تاني للpractice in Egypt, and I'm presenting a case of STEMI, which is now an everyday practice in our country. لكن أنا عايز برضو أطمنكم إن that this is not the usual practice. إن إحنا نشوف حالات يمكن يكون it's not a straightforward case. عشان اللي بيشتغلوا من الشباب الصغير اللي بيشتغل primary PCI, we want to promote this technique. Primary PCI is usually straightforward and simple in most of the cases. Maybe in 10% of cases you might find some deviation from the usual form. So this is Mr. Ibrahim, is a 60-year-old gentleman presenting with chest pain on and off for the last 24 hours. Blood pressure was 80/60, heart, no additional heart sound except for a faint S4. Chest was clear despite of this hypotension, and the ECG showed ST elevation in the anterior chest leads. And according to the presentation, there was a decision for primary PCI. We decided for a femoral approach, 6 French Jotkin left 4. The RCA was injected and it showed no significant lesions. I think you can appreciate here a totally occluded LAD, as you can see in this view. This is another view, an areocranial. Again, you can appreciate the culprit lesion, which is the totally occluded LAD. It's a proximal LAD after giving the diagonal. This is the spider view. Again, you can see a rather diffuse disease in the left main, if you would appreciate it. Again, with almost free ostium of the circumflex. And again, a total occlusion of the LAD after giving a diagonal of a sizable diagonal. So the PT2 wire was available in the cath lab, and it passed actually easily. And we decided for a small balloon for pre-dilatation, 1.5 by 20 at 14 atmosphere. Now this is a stent, a drug-eluting stent, 2.75 by 28. And this is the flow after the stent, TIMI3 flow, after putting the stent. But as you can see here, that the patient was still hypotensive, although with no chest pain. And we started to see some sort of haziness. Again, this was the diagnostic before the procedure. Nothing was appreciated in the spider view, but if you revise again, because we were not sure at this time whether this haziness was present before or this is an iatrogenic, perhaps a thrombus that was formed during the procedure. We were not sure, but I think that if you concentrate on this view, again, this is the diagnostic view, before the start, you can see, again, this is the LED when it was still occluded. You can see the haziness present before starting the procedure. And perhaps this might again explain why was the blood pressure still not optimal. This is another totally different patient, because I would like to make a little comparison between both. This was another patient, a 35 years old male with chest pain on exertion, with non-specific ECG, almost normal ECG, with normal hemodynamics, and presenting for an elective coronary angio because of his chest pain. And here was the surprise. There was a thrombus in the left main, as you can appreciate. Yes. So I'm putting these two cases to see how would you deal with the first one, with the first patient, which was an emergency, and with this, again, kind of patients. You can see here the thrombus. We decided for this patient, for the second patient with the thrombus in the left main, to be conservative and to put the patient on intravenous 2B3A antagonists, of course, plus oral dual antiplatelet therapy for 48 hours. Unfortunately, after 48 hours, still there was a thrombus in the left main, and still we were again refrained from putting a stent in the left main because of the stable condition of the patient, and we were not sure that putting a stent was the correct thing in this normal coronary arteries, as you can see here. Otherwise, all the coronaries of this patient were totally normal. So we give him, again, 2 weeks of dual antiplatelet therapy and warfarin, and fortunately the patient had a normal left main after this 2 weeks of conservative treatment, and he was safe putting him a stent in the left main. This was at presentation with this thrombus after 48 hours of intravenous 2B3A antagonist, and after 2 weeks with a completely normal left main. Back to our patient, we got again this caudal view, PA caudal view, to make a better assessment of the distal left main. As you can see here now, we can see it clear. A big thrombus in the distal left main, on top of an atheroma. Definitely this left main is not a healthy left main, not like the second patient.
I think, Sameh, this is a ruptured plaque in the left main. Ruptured plaque in the left main.
Ruptured plaque.
Ruptured plaque in the left main, yeah.
You might have this, again, possibility. Now this is a stent, 3.5 by 32. From the left main to the LED with some overlap on the proximal, on the distal stent. Stent inflated. Flow after the inflation. We were in an emergency, so we did not put a wire in the circumflex, and so the first thing we put was to assess the ostium of the circumflex. I think it's TIMI3 and maybe some haziness, but I think it's okay. And what was, we were thinking of the next step, whether to make a pot or not. We preferred to make a pot because we're not using an IVUS, so we chose to put a large balloon, 4.5 by 15 at 16 atmosphere, keeping the risk of distal embolization in this thrombus lesion. And this is the final results. Some slow flow in the LAD, but I think the results in the left main and the LAD was okay, and the circumflex again was okay. And I think this was the end result. So my take-home message from this short case is that in a setting of emergency PCI, don't underestimate a patient with STEMI and cardiogenic shock. Please keep some time in more projections. Don't limit your projections and views. because there might be some hidden lesions that might not be appreciated in the first views in this emergency situations. Take your time after fixing the main problem to take other views in order to be sure that everything was okay. And the final message was that keep the job simple, efficient, and quick. Thank you very much.